Obviously, the topic for today is big data, and we're going to make this a little personal as well. And what is your current, whether it be your organization or yourself, relationship with big data? Where is it at in your organization? Does it make your life better? Does it make it worse? So we'll start.
Okay, good morning. I lead actually the Big Data and Innovation Center, so the big data is a part of my name. We collect data for many years. We started with the electronic patient record. Actually, we didn't think about data when we started with electronic patient record. We thought about digital paper, but with the time we understood that the real thing is the data. And I think that we have a really unique place now in Israel and in Maccabi, that we have longitudinal data, we have unique ID. We use the data, so we QA the data, so the data becomes better and better. But lately we understand first that there is a lot of data which is unstructured data, and we started dealing with text and images and voice files, etc. But more that we can't rest. And if we'll only use our data and we'll be so happy with what we have achieved, we won't get there. And that's why we actually started a biobank. And we went to our patients, which are the best collaborators to work with. And we asked them, in Maccabi we have one mega lab, one lab to all the country. You have 350 collecting points. So we asked them, would you mind that each time that we'll take some blood, urine, etc., we'll take some more and we'll keep it in our refrigerators, and we'll be able to go back and research with the biological specimens, and then we'll be able to use genetics and biomarkers and more. And I think in a very short time, we got more than 75,000 patients within the biobank, and we'll have a lot more this year. So I think using the data is one issue, producing the data, keeping the data, not losing valuable data. So data is all over, and we have to be very smart in order to produce it and to use it smartly. I think that in Israel as a whole, in Maccabi, as I see it, we can implement what we produce with the data, and that's a huge advantage. We have a great beta site to use the data, and many times when you see the product prospectively, it's a lot different than seeing it historical perspective. And that's the challenge, to use it and to do better precision medicine in our organization. You can't do it by yourself. You need partners. Only with good partners you can do it. And that's what we try to do.
So I'm sure most people know who you are, but also give your name and title.
Okay.
Most people probably know who you are.
Probably. So my name is Varda Shalev. I'm a family physician. I practice twice a week in my clinic in Rosh Hashanah. I have a partner for many years. I've studied medical info. I did my postdoc in medical informatics in Johns Hopkins, and then I came back to found the medical informatics department in Maccabi. Then I was the head of the primary care district in Maccabi. And now I lead this, and I think I teach in Tel Aviv University Big Data and Medical Informatics, and I think that's another challenge. How do you use it with students? How do you teach students? Because the old physicians, it's a lot more difficult for them to accept innovation. Thank you.
I could expect. So hi, I'll start just with self-introduction. So I'm Ron. I'm a public health physician, and I am the closer. Now you hear better. And I am the founding director of an institute called the Clalit Research Institute. We've had the pleasure and the privilege to actually start this movement. Over 10 years ago, we started the first big data innovation center at Clalit. Clalit, for those of you who are not local, is basically half of the Israeli healthcare system. It's ensuring 54% of the population and has 1/3 of the acute hospital beds in the country, and has put on, again, electronic medical records over 20 years ago, collecting all the data. and started things like data interoperability and data sharing in the country, creating the first data sharing platform that later on became a national, the first research institute, the first implementation of data-driven predictions, etc., many, many years ago. So our first predictive models have been put in practice 13 years ago. So I think that is what's being a little bit ahead of the game. Now, currently speaking, I think that we are a little bit falling in love in the processes and in the data and in the data, all of the issues of collecting the data. And I think the key issue was mentioned very well by John in his talk. And it is, how do we prevent ourselves from calling the digitization of current processes and calling it innovation? And that is a huge mistake a lot of people do. If you take a broken process and you digitize it, it continues to be a digitally broken process. And I think the power of data that we have right now is really for care redesign. And we're in a unique position in time where data is an enabler. It's nothing more than that, because it can easily put you out of the right path. If you know what's broken in the care processes that we have right now, and our care processes are broken, even in the best places, even in one of the 10 best hospitals in the world, they are broken. They are broken everywhere. And we're providing futile care. Errors are killing masses of patients that wouldn't be acceptable anywhere else. And we're not giving the care that we should be providing. And we have an opportunity to use data to change that. So what we try to do at the Clalit Research Institute is to do the movement that was mentioned this morning, from data to tools and policies that try to actually change that. And we have the ability to implement them, and we have been implementing them, both alone and with startups that have partnered with us, have used our data, and have created great things. We might have time later on today to talk about it, but I want to be brief.
I have a microphone too. Hi, I'm David Rich. I got to say hello to you before. I would just say in the briefest sense that my relationship with big data is trying to take magical thinking, which there's so much of, and try to translate that and overcome the tremendous obstacles that we all face in working with established electronic medical records, with clinicians, and this is not just physicians, it's nurses, it's social workers, it's dietitians, and it's administrators, and creating real applications that make people's lives better. And so that is the relationship with big data. It's about being, in some ways, an evangelist, and a little bit of a prophet, hopefully not a prophet of doom, but a prophet of great things for the future, and helping lead bright people to create new solutions.
Hi, John Halamka, farmer, doctor, winemaker. What we are challenged by is data governance and data curation. And let me give you an example. So if we're going to use all these wonderful AI tools on the historical data we've all gathered, well, we don't understand the biases and the problems in that underlying data. So in the Obama administration, 2009, you lived the dream, we started doing medication reconciliation. So suddenly we started adding many more medications to the medication lists than we had previously. So our AI systems have literally said, in 2009, everyone got sicker. Well, no. It's just the nature of the data quality changed, and there were all these biases. If you look at our historical record, we don't record as much rich data on non-English speaking patients, sometimes because it's just harder to get the information from them. So again, we use AI models, and they would be biased about the care of these patients in the future based on the nature of the data of the past. So figuring out where the data is good and bad, for what purpose, and removing bias is a huge challenge.
Thank you. So my name is Nathalie Bloch, and I'm a physician, almost a primary care physician. I was in Boston for 14 years, and Eyaz in the Quran is the one actually who brought me back to Israel to build and direct the Innovation Center for Digital Health at Sheba. So Sheba has an electronic medical record since 1994 and paperless since about 2003. And actually, we got the mandate in our innovation center to sit on all this data warehouse. Our life is totally connected to the data. And from my experience as a physician who took care of almost 3,000 patients in Cambridge, Massachusetts, I'm not practicing anymore, unfortunately, I realized that the main issue of how you can really help patients, especially when we become mostly population managers in medicine, is really trusting and depending on the data that was accumulated prior to us and to be smart enough to know how to use it. So it's either by creating those new models and algorithms and softwares that we can do in-house with our physicians, depending on their needs and pain points, while using our people at the Innovation Center, or by implementing new technologies from startup companies and other technologies within the medical care in order to really create a better value with better outcomes.
So we'll stay down at that end and do the same thing, working ourselves back. I don't travel as much as Crazy John down here, but not far behind him. And I get to go to a lot of different countries around the world. And generally I hear from chief executives the same thing everywhere. We've put a lot of money into investing in IT solutions now, in some cases obscene amounts of money into those. We're looking forward now to spending a lot more money on big data and all this stuff that's coming. How are we going to get the real value out of this? And how do we make that proposition for value? Whether you're a startup or you're an executive in a big health system, trying to make the pitch to spend sometimes millions and millions of dollars or shekels, whatever it may be.
So I think that we have no choice, actually. It's not really about creating a luxury position where you are using new technologies. It's really about taking care of patients. So the population, and it was said here before and many times earlier, the demographic changes make our population older. They carry more chronic diseases. There are no ways, current ways for us to take care of this huge demand, and things will just get worse. So using the data is a necessity. Trying to create those insights that will help us to take care of patients in a larger scale is the must. The money that we have to invest in that, yes, it's big. It doesn't mean that we will actually cut our people down, like that we will have to fire patients, like employees, I'm sorry, but it's really tunneling this kind of activities to more efficient and creating more value for a larger population and an older population that carries even more chronic diseases.
John?
So you've asked, how do we realize the value of our investments? Well, the problem is value takes many forms. So how does Beth Israel Deaconess and now Beth Israel Leahy look at value? Well, quality. Let's say we're going to improve our quality. That's one kind of value. How impactful can we be on patients and doctors and staff? So impact factor may be another value. Is there a regulatory or compliance mandate? Well, that can be kind of a value. Is it strategic? That is, if we're going to be known as the most digitally savvy healthcare system, oh, maybe that's of value. But ROI in IT is pretty hard to measure, and you know, traditionally, in a P&L, IT has always been an L. It's always been a cost. It's not really been a profit. So how do you pivot that? So in the world of value-based purchasing, what are we starting to have to do? We have to take your clinical data, EHRs from the 70s to the present, and we have to take your financial data, all the payer claims data, and we have to take your Internet of Things data, and we have to take patient report of outcomes data, and bring it together in some sort of coherent data structure where they can do care management, guiding the patient through the process from that entire collection of data. What have we seen so far? Well, in our accountable care organization model, it's early days in this, we saved Medicare $50 million last year. Now, you know, these ACOs are all in a mixed bag. But by being able to say we've aggregated everything about your longitudinal experience, cost, and clinical data, and we've been able to direct your care more effectively, that has finally shown some savings. So there's sort of a reasonable ROI or value proposition.
So David, you're chief executive. How do you make the pitch at the highest level to go spend more money?
Well, it really has to come down to not just the economics, as we've talked about, but to the ability of a practitioner to provide better care. We are not really yet in a population health world. We're really in a fee-for-service world, which is morphing towards pay-for-value in the U.S.
Right.
And so in that effort, what is going to make my life better and that of a patient better at the same time. So for example, if we are able to reduce readmissions to a hospital within 30 days, that has become a major penalty. So penalty avoidance in terms of providing better post-acute care for a patient. That is just one example. And I'm just going to give a couple of examples, obviously, in the interest of time. Later on in a lecture I'll give later today, I'll talk about just the example of getting dietitians to the right patient at the right time. Using work that was spearheaded by Dr. Matt Levin, who's sitting here in the audience today, and his team, we were able to use really just it's not brilliant these days, as we talked about the 16-year-old over a weekend being able to do great science. It did take our team a little longer than a weekend, but using a random forest model, every morning when the dietitians come to work at Mount Sinai Hospital, they receive a curated list, and so that they're more likely to make a diagnosis of severe malnutrition, to treat that patient. And in our healthcare system in the US, the case mix index number increases, our observed to expected metrics improve, and frankly, we're also reimbursed more because we're reimbursed according to complexity. So that's just a simple example of how we were able to take a big data application and make things better. In the big scheme of things, I need data to influence the way people provide care. It can be just as simple with no big data of just showing a surgeon what their transfusion rates are. We always joke, I'm an anesthesiologist, I don't know how many surgeons I'm about to offend, but we always say, a surgeon's only as smart as his last case. And why is that? It's not just because I'm picking on surgeons because I'm an anesthesiologist and it's fun, which is part of the reason. But it's also because, you're a surgeon? Oh, sorry, family practice. But it's also because what we need to do is to have people learn, as Kahneman, a Nobel Prize winner and an Israeli scientist, talked about the heuristic of representativeness. That's the translation of I'm only as smart as my last case, because we learn by experience. So how can we take the experience of millions of data points and translate them into daily information that a practitioner, this isn't just a doctor, a nurse, a social worker, etc., can use in a real-world environment to make our patients have more coordinated and more effective care.
Thank you. So I think that the key aspect in your question is what is value. And so talking about that, I think there's the way we work is there's a very simple method, which is look at the quadruple A. Start with the basics. You can impact one or more of the basic 4 factors. Either you impact measurable quality, or you impact measure level of service and patient experiences, or you have an impact on overall cost and leaving everything else constant, or you improve the experience of the physician and the caregiver and the nurse. And each one of these is fair enough. If you can bend the curve and if you can make an impact on one of these 4 and hopefully on more than one, then it's a win. But it's not enough to say that you do. You have to show, first of all, that you are able to make a difference, and then that this difference is what we call in medicine clinically significant, not just statistically significant. That it actually makes a real dent in real life. So it is extremely okay if you have a solution, an app, whatever it is that you're bringing to the table that's based on data, and what it's able to do is only makes the physician's life in an everyday work less miserable. If you're able to do just that, it's a win. It's a huge win. Right now, the way we provide, especially primary care, I mean, it's not fair. It's not fair for the patients. It's not fair for the physician. They're doing a lot of technical, mundane work that they should not be doing. Technicians should do this in a very affluent system, which they do in the US. And, really, really stupid machines, trained monkeys, would do that in an AI system. So let's try to do that. Let's try to take away some of that mundane component of the work and move it into the data-driven apps. So this is one aspect. The other one is keep everything constant and just less waste. So let's make things a little bit more cost-effective by taking away the futile components of what we do and letting machines help us in some of the examples that you guys have given to do a little bit less of that. And at the end, there's quality. And the only problem with improving quality today is that nobody pays for that. And it's very difficult to measure, and we say we measure it, and we say we try to improve it, but it's really driven on our own interest as responsible organizations to go there. Nobody compensates us in any way as we go ahead and improve quality. We keep on investing in it. Most of the effort that we have at the Clalit Research Institute is towards improving quality. But that's the one component that nobody, except, coming from the true nature of us as physicians who want to improve population health, has any compensation scheme for. And that is something we should consider changing, but the big challenge, which we don't have time to talk about today, is how do you measure that, and what in quality improvement actually brings value. And here we come to patient-reported outcomes and measurable outcomes, but that's a different talk.
You're kind of new into this position, and you're going to have to defend all the money and the value that you're going forward. How are you going to do that?
So first, there is a tension between the physician, the patient, and the provider. And usually when you improve one, you don't improve the other. We don't go in the same directions, unfortunately. So we have to decide, and I think that the patient has won. We have to think about the patient first, second, and third. And it means, like David said, it's not all about money. So when I come to my CEO, and we have done it, for example, with the colon score, which is something that predicts that you are going to probably have colon cancer based on your CBC. And it means that he will need to do more colonoscopies now. And the queue for colonoscopy is 3 months. But when I tell him, look, the positive predictive value of our algorithm is even better than positive FOBT. So he says, okay, of course we have to do it. Or if we we have a contract with IBEX that we did digital pathology. So we found an algorithm that predicts, like a pathologist, prostate cancer. But the machine does different mistakes than the physician. So when we tell him, let's put it as a second read, so you will need to do 5% of second read. You have to invest in it, but you will get an outcome. And the second day that we implement the machine starts to shout positive result on a negative result of the pathologist. So the CEO can't stand silent in front of it. And even if it costs money, he will implement it. And we implement many algorithms within the organizations, although they don't save us, but they save our patients. And I think another issue is to go directly to the patient, because many times if we'll give the information for the patient and we'll give him privileges to do things without us, we are going to even save money with new innovations. So I think it's possible, and it's not only about money. Of course, we can save a lot of money, because I think that today we spend too much money.
So king for a day, queen for a day, whichever you prefer, prime minister for a day, president for a day. I know John wants to already replace the one we have, so John's already running for president in 2 years. So
half the country is running for president. So.
That's true. Welcome on your run. So for any of you, you're king for a day. You can remove one obstacle that you know you're being presented with today, or over, say, the next 24 months, that will make big data much easier for you to implement and get the benefits from. What obstacle would you wipe out? What challenge is out there that you just said, if I could snap my finger, this would be gone, it would be fixed, and we can move ahead?
Innovative regulation. Unfortunately, the chief scientist went before, but I think that the country and the regulation should be a lot faster, a lot more innovative. They should have SLA that is a lot different than now, that will be able to implement, for example, clinical trial, the higher genetic committee, many issues that if we could do it faster, because when you talk about innovation, it should be fast. And I think it slows us a lot. And another thing is using the infrastructure, the unique infrastructure that we have in Israel. Let's not do it like everywhere in the world, because we are completely different. The challenges and the opportunities are very unique here in Israel, and we should use it in order to do it differently.
I think that one of the key pain points of every organization is legacy IT systems. Anybody who's ever tried to get an innovation into an organization found that one of the key challenges lies there. And so, king for a day or a magician for a minute, I would really restart a lot of the basic legacy systems currently in place and redo a whole layer of APIs above them that make them, completely a matter of the past, and all of the allows introduction of every new app, intervention, add-on to be seamlessly integrated. And when that is possible, I think the clinicians would be so open to test driving so many of those new things that we bring forward. And the friction right now is so great that you have to think too many times before you actually go ahead and field trial something.
David?
In my world, in that magical moment, what I would do is be able to align the incentives appropriately. So, for example, in the U.S., it's illegal to pay a surgeon or an internist in certain ways based upon, let's say, productivity, unless it fits things like a relative value unit. And that can create a perverse incentive, such as more desire to do more colonoscopies or more MRIs or more surgeries or more catheterizations. And if instead we could align the incentives of the providers, and this is not just a physician, I'm talking also about a nurse and a social worker, and frankly also a patient, to be partners in providing value-based care, that would be my magical moment.
So Russ, why don't I take on our favorite issue? So are you a TSA pre-check or global entry person?
All of the above.
Yeah, so why did I give up my privacy to get this biometrically enabled national identifier? Well, it's because when I land from China back in Boston, I'll be at my car in 2 minutes. There's no immigration, there's no customs, there's no lines. But I had to give up my fingerprints, my retinal scan, my passport, my marriage certificate, and all of my historical demographics. But it was my choice. Well, in the United States, we have no nationwide patient matching strategy. It's name, gender, date of birth, cell phone number, email address, whatever. It has at best about an 80% positive predictive value. Probabilistic statistical refinement with other kinds of, maybe you can get into the 90s. It's still bad. And so we have not as a country unified, and I don't mean necessarily a mandatory top-down single number for healthcare, but a nationwide patient matching strategy that we can all use. That's what I would do.
You have my vote, by the way, for president.
Yeah, thank you.
Totally. So can I say more than one, or all of the above, and we'll add some more? So there are plenty. I think that most of them are quite easy, not easy, but will be solved soon, like legislation and regulation that hopefully will make a few changes, including cloud use. I heard you yesterday saying that you're using Amazon for operational. This is unheard of at this point here in Israel. But I do think that the integration part to the IT systems, especially in our place, is really the toughest thing that we face.
So on a similar note, and I've seen it here, and this is my 6th trip here, of which 3 were tourism, 3 were business, but I've been all around the world, and there seems to be a huge void of digitally literate leaders. Whether they're chief executives, David, you are an exception beyond any belief. You're probably the most digitally literate chief executive I've ever met. But most, some of them still print out their email. They have an assistant print out their email and they handwrite a note and somebody else puts it in. How are we going to think about generational divides? The generation that's been in this full swing that are now being forced into a digital perspective, how are we going to get them to where they're not only just digitally literate, they become digitally excited and they want to explore this whole new world?
So first of all, education, of course. I believe that most of us teach and know and understand the importance of that. So definitely in medical schools to start teaching more data science. But also at this point, once we have like this big organization like Sheba with 9,000 employees, I do think that creating a satellite of a different IT system parallel to the current operational system that is serving the needs of the hospital, but the digital platform that will actually change and transform the hospital, this will be actually a good ambassador for the rest of us of how to do it, what will be the next step of us while using the digital platform when we do research, but also when we operate in our clinical daily life.
Right. It's going to be a journey, but let's make it an existential question, which is 80% of all the accesses of Beth Israel Deaconess software by the public today is via phone, right? So unless you are a mobile producer, you will not be a healthcare system of choice. Unless you are providing APIs for patients to download their data. I mean, the patients and the customers now coming to us saying, give me my data. And in a value-based purchasing world, unless you're sharing data, you can't survive those risk contracts. So the CEO may not be digitally native, but if the very existence of the organization depends on innovation and digital competence, change will happen.
So I will quote Dan Michelson, who's a brilliant strategist in healthcare in the U.S., and I think he runs Strategy Decision or something. It's not meant to be a pitch for him specifically, but he wrote a very, I think, a very inspirational piece after the a recent healthcare conference, and he talked about it, and he harked back to a Clintonian era thing, and he said, "It's the platform, stupid." If anyone remembers, the Clintons used to say it's the economy, stupid. So in healthcare, it's the platform. And whether it's the CEO who's overwhelmed with a signal-to-noise problem with too many emails that are not enabling her or him to act effectively, or it's the pajama time that you referred to previously where our overworked providers are tortured by the platform of the electronic medical record, or whether it's patients who are defeated by phone trees and lack of digital access to the system, creating platforms that enable people to interact appropriately in this new digital health workplace, that's the secret. Removing the pain, creating effective value for the people who provide the care and people who receive the care.
All of these were great, valid points. The only thing I will add that we have the, I think, obligation to train the next leaders that will take us forward. Because the question, as John said, it's not whether or not it's going to happen. Every CEO will understand this is an imperative. The question is how fast will we act? And so if we want to bring the future a little bit more quickly into where we are, we have to train the next cohort of leaders. And so you'll hear today at this conference some of the people that are training right now to become the next leaders. And I think they can kind of sway the whole system. You know, it takes just a few brilliant people, devoted, capable, that would be injected to the right decision-making point in every organization, and they can pivot the whole organization aside. You can see this. This is a singular point that makes a huge difference for entire big, heavy organizations. So if you create a cadre of such people, you know, that's the hinge point which makes you able to change and move the world.
I think that we have, when we bring, now with AI, which is actually a black box, we'll have to be more transparent to develop tools that will feel that even though it's a black box, it's transparent for you to understand how it works. Because it's the new physiology for us, the physicians, for example, or the managers, to count on this black box and to decide that it's value. And that's really a challenge. It's not easy to do.
So we have time for one quick question everybody can answer. This is another one of those dream worlds you have. 5 years from now, you and your organization, Sheba, Clalit, your organizations, Maccabi, you nailed it. You got big data perfect in the next 5 years. Everything's perfect. Tell me something that would be massively different in your world 5 years from now.
The number needed to treat is a lot lower. So today, if it's on average 1 to 20, you treat 20 patients, one will benefit from a drug, it will be 1 to 10.
Okay.
the work of the physician, and especially the family physician, goes back to being empathy-based encounters. And what he does is actually cares for the patient and uses almost all of his time to listen, to interact, and to become the medicine that it can be for that patient without the need to do anything which is mundane, technical, or just time-consuming.
David?
I'll amplify on what I talked about before in terms of the integration with the platform, which I think is really just another iteration of what you've just heard from two other very, very intelligent people, is that we have to remove the pain points. And if those pain points are incrementally better in 5 years, I will be incredibly happy. If our family physicians know which patients they're supposed to call to encourage them to come in and to get treatment, if our clinical diabetes educators know which patients for which we have full risk, they're going to intervene. If our advanced heart failure team knows which patient to call and yell at them, they're not allowed to eat potato chips the night before because the weight went up on the scale, we will have a better world.
So this is going to be probably a controversial prediction. Ward beds will cease to exist. And that is, we will have two kinds of care. There'll be the emergency room, because you still get hit by cars or whatever, and there'll still be ICUs. But ward beds will be now care delivered in the home, telemetry from the home, and monitoring by virtualists. Now, so that is, instead of our ward beds, we're just going to put in offices where virtualists will be caring for patients remotely.
Wow.
Sounds great. So I would add, so if we are able in 5 years really to have everything in place, including new technologies that are based on this data, and we have some kind of really an influence of redesigning healthcare, not just by caring of people more at home in the community, because that's where they belong more than the hospitals, but also to be able to prevent and to identify before things happen, to try to prevent cases where people come to us when they are completely sick, waiting in the waiting room, loaded with other people, but rather really being ahead of time and knowing what will happen. I think that this is really a dream.
So I know I speak for all, at least especially here in Israel. I think you all are in great hands with people that are going to drive big data for you. And I know for our colleagues across the United States, thank you for both what you do. Please join them in giving them a round of applause.